looking at somebody who's not saying anything. The next thing, Lindsay, have you information about the training day yet?
No, I'll mention it at the end of the meeting.
At the end of the meeting,
Yeah,
that's fine.
thank you.
Just so we don't forget, early next month we've got a training day over the theme 3, the specialist surgical thing, and it's been changed and dates have changed and location have changed. Lindsay's going to sort all that out before we start. Right.
Yes, Chair, we've just received one apology, and that's from Councillor Stella Smith of Bury Council.
Okay.
Yes, Chair, daughter employee at Oldham Clinical Commissioning Group.
Minutes for the last meeting. Anything in there that anybody wants to raise? In that case, can you move them, please? Good. In that case, good morning, Warren. Over to you.
Thank you, Chair. I'll do a couple of introductions and offer a bit of background to the report that was circulated. Hopefully, colleagues have had a chance to cast an eye over it, and what we'll try and do is kind of bring to life some of the key features of the work that we've been progressing through the mentally healthy schools pilot. First, introduce the lead on behalf of pretty much the entire education sector, actually, throughout this process, Lisa Fathers, who's a head teacher. And I think critically kind of gave us the hint that if we were going to be successful in engaging schools, we would have to do that, kind of starting from where the schools were. So it's been key in brokering some of that relationship, and we'll describe that as we go along. And just joining us,
apologies.
Sandeep Rowe, who's the Medical Director at North West Boroughs and is the clinical lead for the Children and Young People's mental health work stream overall. And it's worth just, I think, telling the story of how this came about, really, because the committee is asked to focus on the mentally healthy schools work in particular, but worth recognising that's taken place in the context of really quite a significant and ambitious Children and Young People's mental health work stream across Greater Manchester for the last 2 and a bit years. And that's involved something in the region of 70 or 80 million pounds worth of investment, with focus on driving up access to and the availability of mental health support for children and young people requiring that support, and has seen major shifts in the availability of that provision, alongside a significant programme to strengthen the crisis provision across the whole of the day and the night for children and young people across Greater Manchester, and work with new families and support for new parents and so on at the same time. But one of the things that happened that we weren't describing at the start of this process was the provision of mental health support in schools and education settings. About 18 months ago, the government published a green paper on mental health provision in schools. And it was going with the grain of thinking and relationships that were starting to develop because of the way we work in Greater Manchester, and because actually the public sector connects in this way. So we thought we were in a good position actually to set the running on what implementation and spread of that kind of provision in schools might look like. Probably worth handing over at this point with a kind of brief on bringing the story to life in terms of what was our approach to the model, where did we start with I think was it 32 schools in the 31 schools in the first cohort. What have we learnt? What's the impact and effect been, and where are we going next with this? And what does spread and availability across Greater Manchester look like, and how do we think we might achieve that? So if that's okay as an intro, I'll hand over to Sandeep and Lisa.
Okay. Thank you. Good morning, and apologies again. I'm also a mum of 3, and my youngest, it's first week at senior school. Yeah, so actually, quite poignantly, that transition is a really, really crucial transition for all our children, and that's been a big part of the programme, actually, that year 6 to 7 transition. So I'm feeling it for the third time. Possibly it's taken me this long to actually realise. A third time lucky is what I'm saying. So I think it's also comes from a really personal, it's personal to me, it always has been, but it's also hugely vital for the future of our children. They make up about a third of the population in the country, but actually they are our future. They're the people who are going to look after us. They're the people who are going to lead our communities. They're going to be our future teachers, politicians, and that's very important and crucial for us. So I think it's a long time coming. Warren very helpfully mentioned the Green Paper in terms of our journey. Just before the Green Paper, we had Future in Mind in 2015, which was the government-commissioned report and piece of work that brought about 80 or 90 experts from all over the country. For me, in my 23-year career, it was the first time that I felt the whole system was represented. And that sounds ridiculous, but actually it felt like for the first time you had education partners, social care, local authority, politicians, commissioners, clinicians from a variety of sectors, really, really coming together to child and adolescent mental health services had been described as a car crash, not here in Greater Manchester, across the country. As a consultant child psychiatrist, that's very difficult to hear, but I wouldn't disagree with that. It was our opportunity and it was our gift, we believe. So that was about transforming the whole of children's mental health services, not just specialist services, but very much from prevention to treatment. And I think that's very key, prevention. And that's very much part of the devolution ethos, the devolution offer. It was very much about what do we need to do better around the health of our population holistically. What does wellness mean? Moving away from a culture of illness to wellness. And actually, mental health needed to play catch-up for a long time, and too long we have been under-resourced, and it's not just about money. It's also about the parity in terms of the culture, the stigma around the understanding, actually. If you don't understand, people are intelligent. If you give them the tools and you educate them, actually education is one of our most powerful tools to make change. And that kind of underpins the Mentally Healthy Schools programme. Now, there's a lot contained in the paper. Very happy to take questions because there's a number of sections in terms of what we are doing to support mental health and mental illness, two different things. So good mental health in kind of comparing to physical health is why we encourage people, to look after their hearts, to get their exercise, to eat well. Similarly, keeping good emotional health is important. So there's that side of it. Mental illness is different. People will still get unwell. People will still get ill. So how do we ensure they get the right access treatment at the right time, quickly and easily? So there are two elements to the work that we're doing across education settings. And I think we wanted to concentrate on the schools programme, but very happy to talk about any of the other bits. The Green Paper had three kind of key areas. What we said we would do, and again as a clinician, and it's not because I'm kind of leading things, I believe devolution has allowed us to be, I would actually go out on a limb and say, the only place in the country who's been able to do this. And I believe that's because of devolution. Okay, good. So I do hope that, and that is not about keeping it to Greater Manchester. This is about sharing good practice and learning across the country as a trailblazer site. And we're very keen to do that. It was very exciting, therefore, as a clinician. I've never been able to work with my colleagues in education like Lisa in the way that we have done through this programme. And that's refreshing, but it's also been the success of the programme has been that. None of us can do this alone. We have to collaborate. We must collaborate for the good of our children, young people and their families and the communities. So that's been one of the successes. So what we committed to doing was the first two themes in the Green Paper we wanted to answer. One was working with schools to raise awareness and support the training of designated senior leads in schools with mental health awareness training, deliver mental health first aid training to school leaders, which Lisa will talk about, and also to deliver awareness, but also some group work with our young people at transition point stages around good mental health, how to look after your mental health, and to do that through the power of story, through mentorship. So we've used youth sport trust and athlete mentors. And those were the first two bits, as well as starting to bring the element of specialist child and adolescent mental health services to support schools. So we weren't bringing in a team at this stage to actually do face-to-face interventions and assessment. It was the first stage of each school in the first phase of 31 schools would get an hour either face-to-face or telephone conference meet or WebEx. Not all our schools actually have the technology to do that. That was another thing that came out of this programme. So, you know, there are certain things that we know we need to be able to enable schools and enable ourselves so that we can deliver good care, because it's digital technologies can really help us. So that was an eye-opener in itself. But each school got an hour every month with a specialist CAMS team, which was around, okay, how has this month gone? What are the themes that are emerging? How is the programme going? And is there any, you know, it was a consultation. So we could actually support them with advice, information and signposting. And that was what we did through the rapid pilot. And that was phase one. It was very key for us that we weren't robbing Peter to pay Paul in terms of workforce. That's one of the big issues we have across the system. So there's no point us taking workforce from specialist CAMS to go and deliver this. That wasn't the point of this. This was about the system coming together to deliver better care, to join up a system that felt disconnected for our children, young people and teachers to get the right support at the right time, and to also ensure that can we sustain this for the future. So what we were doing is working with 4 of our voluntary and community sector partners, and it was the voluntary and community sector partners that were delivering the actual Mentally Healthy Schools programme across the schools, with Greater Manchester Health and Social Care Partnership being the facilitator, so we had good governance, which is important, and specialist CAMS being part of the development of the model and the supervision. So that was the pilot bit. I'm going to hand over to Lisa just to, you know, some of the elements of the pilot.
Hi, good morning everyone. So just to give a little bit of context, so as Sandeep said, you know, we felt that this was really needed in Greater Manchester, but from a schools point of view, we've got greater accountability on schools, you know, the changing landscape of schools in terms of budgets, exams, accountability, you know, the changing nature of the world we live in with social media, etc. And all that obviously feeds into the health and well-being of our teachers, our school leaders, and ultimately our students. So what's been really nice about this project has not just been the cross-sector working, it's been the genuine learning across the sectors. And so I'll just take you through kind of what it looked like on the ground, because you asked me to bring it to life. So I lead a teaching school. I'm the director of a teaching school, and if you don't know what a teaching school is, we work in a kind of outreach way with lots of other schools, and schools are really familiar with this. So the fact that we actually rolled out the pilot and now the programme through a structure that schools were already really familiar with was very helpful for schools, because they're used to that. So that's the first thing. And my team have delivered Mental Health First Aid, which is a 2-day nationally accredited programme through Mental Health First Aid England. And after the 2-day course, our teachers are now mental health first aiders. And we've talked about building almost a new workforce of mental health first aiders, because it is about prevention, it's about early intervention, it's about equipping our teachers to notice and intervene early and talk more about those issues that are sometimes ignored. And this is not about giving teachers more to do, because we've got enough to do already. It's just about helping them do what they already do really well, just a tiny bit better. In terms of whole school leadership of health and well-being, what Sandeep and I often say is that when we talk about health, we want that to include mental health without us needing to be really obvious about it. And so the senior leadership training that Place to Be have delivered has helped schools plan in a really strategic way how they will embed that ethos in the schools and everything that they do. The Youth Sport Trust, that's been a really dynamic and exciting bit of the programme. So as Sandeep said, we've taken kind of ex-Olympians and really famous athletes into schools, and they've worked with groups of students and said, you know, what kind of things does it take for me to get to the start line in a huge race with the whole world watching, and how can we take some of the learning from that maybe to think about how we prepare for a really serious exam, how can we get resilience from the world of sport, and what lessons can we learn and translate that. And we've done workshops in a really active way, which is really important. Many of our schools in the pilot and now the programme have also taken up the Daily Mile, which, as you know, is a big Greater Manchester initiative, and it's about giving our schools more things in their toolboxes. One of our primary schools in Gorton, Stanley Grove Primary Academy from Bright Futures, the children have talked about the fact that they now know where to go in school, whether they've got a sore finger, or whether they're really worried about something, and they've got mental health and physical health first aid stations. They've made that transition, so that's been a really kind of obvious example of how things have changed within schools. 42nd Street have obviously delivered the one-to-one support. If you can imagine that schools have been buying a bit of one-to-one support for very vulnerable students themselves, really in the climate in education today and the budgets that we're trying to work with, the schools have welcomed that extra time for one-to-one support for their children with open arms, and they really have embraced that. But I think the success has been the way that all of the partners that I've mentioned have worked together, so that it's been a real package around each individual school. It's multi-layered, so you've got the senior leadership training, the mental health first aid, maybe for midday assistants, in some cases pastoral staff, in some cases teachers. You've got the work with the students, and then you've got this one-to-one support. The thing that's really helped us to embed the work in schools has been creating a team of young mental health ambassadors. And those children and young people have really championed this work. They've led assemblies, they've changed school policy, and for some individual students it's made a massive difference, and I won't dwell on it because I'm conscious of time, but just to give you a couple of examples, there's a student called Ashkan who's just left Cedar Mount Academy, and he won't mind me saying, because he went on Breakfast TV to say it, that this programme actually enabled him to have hope, and he was really seriously thinking about taking his own life. And actually through the work of this programme, not only has he now got a positive outlook for himself and his future, but he's been able to share that journey with lots of his peers. And there are lots of other examples like that. Is that okay?
And just to say the context is, he was a refugee from Syria, refugee family from Syria, so his story is an exceptionally powerful story. And the fact that he's gone on to be a champion, to support others, is incredible, really, in terms of what we could achieve and what we can achieve and how we can build on this. Yeah, really important. Did you want me to just say very quickly the next steps? Because we've talked about, phase 1, 2, 3. We're in phase 3, about to move to phase 4, which is great news. Yeah, in an ideal world, would we want to reach all 1,200, I think, education establishments across GM? Of course we would. The reality is we're not going to be able to do that from a resource perspective. However, we are going to meet our goal of 10%, which is 125 schools, which may not sound a lot, but actually in terms of nationally rolling out programme, it is. It's good in terms of the learning and what we can build on from this. So what we have done, whilst we have collected and gathered the data and the evaluation and rolled out the programme, is developed a set of Greater Manchester standards, so that there will be standards developed so that schools, because one of the difficulties schools have always had is, how do we know what to commission? We know we've got to do, we know we must do this, and we must support our young people with improved mental health, better emotional awareness, etc. But how do we know what's good, what's not, what's gold standard or not gold standard, and actually how do we know that we're not doing harm as well? So we're very mindful that this programme has helped us to also develop a set of standards that all schools will then have a framework that will guide them to be able to commission a programme going forward, and that might be our programme. You know, some of this is a bit unknown as well, but also we will then, our vision is to have an accreditation process that then we can have GM accredited programmes, because equally there are other programmes. Salford has been very successful in running their emotionally friendly schools programme. There was a national Anna Freud Centre Schools Link pilot programme. Wigan was was actively a participant in that, as was Oldham, Tameside. So there will be other programmes. But what is important is, what we want to see is not that postcode lottery, that if you're in Greater Manchester, whatever borough, whatever locality you live in, as a young person and as a family, you should have the right to access the same standard of support and care for your mental health and well-being in schools. And that's where the accredited standards come in.
Just to add one other thing, it wasn't one of our targets, but one of the things that has come out of this project has been that teachers are saying that their health and well-being has improved as a result of it. And I can't tell you the number of individual emails and contacts we've had from teachers after they've perhaps done the mental health first aid course, because they've said, this has made me stop, think, reevaluate, think about my work-life balance, how I'm living, my health. And for a couple of individual teachers, they've said it could have perhaps saved their lives as well. And I think when we talk about the GM, Children and Young People workforce, we really need to make sure that we're including teachers in that, because if teachers go off and then schools have to get supply staff in, that the impact on the children's health and well-being and ultimately their outcomes when they leave school is huge. So whilst it wasn't an overarching objective at the beginning of the pilot, it's actually one of the benefits and something else that's come out as a bit of a bonus, really.
And just finally, we've mentioned Youth Sport Trust. Obviously, as it was a rapid pilot and it was a pilot, we couldn't include everything that we would have wanted to include in terms of toolkits around prevention. People will be familiar or not at different levels with social prescribing, but essentially it's about what do we have in the community to keep well, what is in all of our toolkits around prevention and also recovery and keeping well, self-management. So physical activity, the Daily Mile, working with athlete mentors, that doesn't mean every child is going to be captain of the football team or the rugby team or the cricket team. I know that from my own 3 kids. My eldest has found climbing. That's his thing. So it's actually about introducing sport doesn't mean you have to be good at football or cricket. Actually, there are many things out there and every individual can be active. It could be gardening. So we are very committed to, in phase 4, the vision is to roll out that social prescribing offer in the offer to include things like actually the arts, music, performance arts, which again, a byproduct of this programme has been a real recognition of how much that has been stripped away from our normal curriculums and actually how vital that is. Whether you're going to become an artist, a musician or not, it's vital for all of us and it's a vital part of young people's emotional development. So thank you.
Questions? Margaret?
Sorry. Does this project cover children with ADHD, autism and SEND children as well? Because I can't see anything in there because they're a huge problem. I've got bronchitis, so my voice is a bit raspy. And the other thing with those groups, I mean, where I'm a school governor, the intake this year has got 60% SEND children, which is an enormous problem. And at the other end, children going out of CAMS into adult services, the transition service, I don't think is adequate. The numbers seem to fall from CAMS into the adult service. So are those areas that you've explored?
Hi. Absolutely. So we have a number of pupil referral units and special schools within the pilot and within the programme now. Equally within the mental health first aid course, we touch on some of those things. As you can imagine, in a 2-day course, it's kind of light touch. But those things that you mentioned are absolutely embedded. And in several schools, actually, the schools have sent their Senkos to the training, and it's absolutely embedded there. Do you want to pick up the other bit?
And it's a very important question. Obviously, in a pilot, we can't cover everything we want to, but we were very mindful and conscious of that. So we have included pupil referral units, special educational needs schools. We've encouraged schools to send their Senkos to do the training as a kind of priority member of staff. Equally, it's about not dictating to schools. It's what, you know, they feel right. What we've also done is worked with a separate piece of funding with further education colleges. So that transition, we often find that young people who've had quite serious mental health problems in their youth may not go on to college but go on to further education colleges. So it is quite a different cohort, and for that reason we didn't put the further education colleges in the Greater Manchester Mentally Healthy Schools programme. We've worked with them with a separate piece of funding, aligned it to this programme, so there's lots of similar principles, but recognise that actually their need is different because they have a lot of ADHD, special educational needs going through, people that have already previously had CAMS who are still struggling with mental health difficulties, but still deserve the opportunity of an education and employment. So we have done that, and haven't got the, I mean, there's a little bit of, on that in the paper. What we're also moving to, which apologies if we didn't, neither of us said in our summary, but it's in the paper, is as the trailblazer and moving into phase 3, you will have been aware of or heard of something called Education Mental Health Practitioners, EMHPs, another acronym from NHS England, but we've got to work with that. And so as Greater Manchester, because we had put ourselves in a really good position having done the pilot programme, we were ready to go in terms of the training of education mental health practitioners. So the funding that's come through centrally, we're aligning nationally to priorities, but we're also doing what we believe is right locally for Greater Manchester. So we've got 8 education mental health practitioners who are completing their training as we speak, and they have already been embedded within phase 3 of our programme in terms of getting their supervision, but starting to understand the programme and the delivery into our schools. What that will enable us is, NHS England's framework roughly has given us, it's given us a framework roughly of 4 education mental health practitioners would make a team that could serve or support 20 school settings. I have slightly different opinion, and also I'm a bit more realistic. Yes. So my opinion, although I've got to check it with Zulfi and Warren and others first because they're like this, but yeah, is that we could, because we've already done different to nationally in terms of the schools programme, because we are one of the few, if not the only, who's actually fully delivered it through voluntary community sector with specialist CAMS and health being involved, but in a different way. We've utilised the workforce and the sectors very differently, but still worked together to deliver. I believe we can do the same with our education mental health practitioner teams, so that our reach could be farther, and actually what we do could be slightly different in terms of utilising that capacity, those trained staff to do things in a slightly different way. We don't necessarily need them to provide one-to-one assessments on everybody in 20 schools. Actually, there are different models working with our specialist CAMS services that we could then have a bigger reach and actually reach those that really need that one-to-one. So watch this space. We're working on, okay, if we get 8 trained education mental health practitioners, ideally I'd love one in each locality, one team in each locality, but we're starting somewhere, and I think that there are some things that we can do that could actually have a bigger or a wider reach, but we've not worked that out fully yet.
Eve.
Yeah.
So just in addition to the 8 that's all there already, Greater Manchester have already approved a second cohort, just to add.
Yeah, I guess the burning question is how can we, in our roles as councillors, but also as governors, which I'm sure we all are, in 3 different schools, including Peru's, and as parents, help get that to the next 90% of places across Greater Manchester, which I think in what was a fantastic presentation and absolutely demonstrates all the things we're looking in terms of fallout of devolution and making that devolution difference. in connecting all those partners. You know, again, in looking at that whole system, we're a key part of that, and I think we need to think about how we can be involved in providing that leadership to spread it. I would say, so as a, just, you know, how vital, needed, you both said it is, and it absolutely is. As a lawyer working across education, health and social care for 15 years, you know, it was this preventative stuff, it was the conversations, it was that resilience within schools, it was tackling that culture, that because that wasn't there, that there was just simple communication and thinking led to such crisis for so many young people, so many families, and the cost that brings, we know, to lives, and then in legal costs and all the other costs of the public sector, you know, it absolutely, I think we would all be huge champions and advocates for going, let's make sure that we can, it's demonstrated, roll it out as quickly as possible to everyone, so it's not this postcode lottery you're talking about. So thank you, and please do involve us. And as a very practical note, I see that you've got on the 30th of September a whole systems workshop. So again, that might be a first step in terms of whether we're invited to come and be involved in that, if that's possible. But thank you.
Yeah, there is an ask back, actually. We have just, obviously, post the pilot and post 3 phases, feel we're in a much stronger position now to kind of review the governance around. So we've reviewed that, and we're going to, as of the end of this month, I think, firm that up further, so that actually overarching around our mental health and education settings work, we believe we need that programme board that is dedicated to look at this for all the reasons you've said. Had we not had the results we got, potentially we would have been in a different space, but we have. And I think that's really, really positive. So my ask is, I would love for you to be, you know, to have membership on that board for yourselves, so that actually you're part of our next bit of the journey for the reasons you're saying, actually. So that would be, if that is possible, that would be that would be wonderful.
Thanks, Chair. A couple of queries. 125 schools in the eventually. How are they being selected? Clearly, from what you've said, it would make no sense to have one school here, another quite separate school 5 miles away. Clearly, around, you mentioned Gorton and your teaching school and their network there. Presumably also a focus on the pilot areas in Trafford and Wigan. Is that the case? But how else are you going to select those schools?
Okay, I can answer and tell you what we've done so far. Yep. So phase 1 was a rapid pilot. We had 10 days to get it up and running. So schools were selected very quickly based on schools that my teaching school was already working with and that the other partners had contacts with across GM.
But Lisa, even in that first phase, it was as much of it was a spread across all localities.
It was, yeah. Phase 2 and phase 3, we've worked much closely with locality leads through Greater Manchester Health and Social Care Partnership, putting us in touch with the people in those local areas, and those locality leads have worked with schools to identify the schools that they felt essentially needed the help more than others. And the majority of schools that have been chosen by their locality leads are really, really grateful. I do think that we can join things up even further, and we're working really hard to make sure that we're constantly re-evaluating lessons learned and how can we work together. So, for example, there's a couple of schools that might be in the same MAT with very similar needs, and one school's been chosen and the other hasn't. So, again, we're just kind of thinking about phase 4 now and how we can still make sure that we're feeding in lessons learned from that and taking that local intelligence as well as our strategic overview.
And all our directors of children's services have been involved in that. So the GM representative for all our DCSs has been very much leading on and overseeing the selection of school process.
One more question, Chair. On this, my wife has been chair of a primary school with, in Stockport terms, does include a relatively deprived area of our community. One issue that she has come across is identifying this at primary school level, child who, Stockport, it's a team around the child, I think is their jargon, but they've hit a major problem if the parents are not willing to get involved, and they found that really so frustrating. So have you found the same sorts of things? Have you found strategies that will allow you to work with the child, with or without support from parents?
So I would empathise with that, having seen that kind of issue myself. What I would say is that through the work of the pilot and the programme, we have started to reduce the taboo around mental health and make it something that actually it's okay to talk about. And that sounds really simple, but that message feeding into parents and pupils means that there are less parents perhaps that would back away from a concern being raised about mental health, and that's just quite a general kind of anecdotal response. I don't know if you want to give a more medical one.
Yeah, so actually, similarly, when you get to specialist services, we encounter similar problems. We also encounter mum wants to, dad doesn't, or the other way around. And they're not easy situations, they are challenging, but I guess I would take us back to where we started on the journey. Education is going to be our biggest tool to make change, and let's not underestimate what we need to do with our communities and our parents. So it's not just in school. I think it's all the work that we're doing through the locality plans for mental health. It's about, we have made progress without a shadow of a doubt in terms of raising awareness and understanding that there is something that is mental health and keeping ourselves well, but there's also mental illness and what that might mean. But we need, as a system, to carry on doing that. So, in terms of in the school setting, I think it goes back to actually starting to involve, I hate this word, but I'll use it anyway, parent champions. So, for instance, if we have parent teachers associations, we have parent governors, that story coming from the parent is much more powerful than coming from me. So if I go into a primary school, for instance, and engage with the children and parents, actually what really makes the difference is hearing from a fellow parent and their story, why it worked for them or why it's important. So I think the more we can, moving forward, there's lots actually we can do. We started somewhere, but similarly, Lisa's touched on the programme didn't set out to support the mental health and wellbeing of staff. Not that we didn't know that that was an issue, but it wasn't part of the remit. However, a byproduct of it has been that feedback. Would our wish be in the future for that to be something that is included for all schools? Of course. But equally, what I believe is that actually we should be thinking about something slightly separate for parents. And it's not going to be that all parents opt into it, but some will. And then you get that organically growing understanding in the school community. So the school community is not just the young people and teachers, it's also our parents. So it's not easy. I don't think there's an absolute answer or guarantee we can give you, but there are strategies and there are things that we can do.
Just to add to that, and I know I'm stating the obvious here, but aside from all that really nice stuff that's very proactive, if a child is having an unmet need, essentially it's a safeguarding issue, and you would follow that route.
Thank you. I agree with Eve that local councillors are in a really strong position to be advocates for this service. Would it be possible, where there are schools in local authorities, if we could know who they are, then we could invite them along to Scrutiny to talk about their process, and then happily spread that good work?
Yes, of course, we can sort that out quite quickly.
Only because I'm conscious that there are, as you say, there is some great practice going on outside of the pilot as well, and it's always helpful just hearing that. So again, anything else that we can do to just share that, and I know you talk about sort of toolkits and resources, and absolutely, I'm really pleased you made the point about, parents and carers, because just as we know for parents and carers of young people with SEND, they are the absolute experts who are the greatest advocates, and the more they've joined up and they become the change makers really in shaking that movement, and the young people, and I've seen the stark difference between different schools to schools where they really have embedded that culture of peer-to-peer support and removed the stigma. And those young people are fabulous at supporting each other and at challenging that. And they will go out and they're sat there. It's not about, you know, requiring additional resources for additional professionals. As much as we desperately need those, we recognise the limitations we've got. So, yeah, anything we can do to advocate that and demonstrate what's working elsewhere. Thank you.
Thanks, Eve. I think what I'd like to just add to that is that despite the fact that schools' budgets are really, really, really tight, of course, schools can also choose themselves to prioritise, you know, putting staff on training and paying for it. And whilst that sounds a bit harsh, it's true. You know, we are here as school leaders to remove the barriers that are there to learning. And in some schools, that might be, you know, paying for a couple of staff to do mental health first aid. Similarly, you know, the schools that have been involved, one of the issues that have come up time and time again is attachment. So some of those schools have themselves then invested a very small amount of money in sending their own individual staff on further attachment training and things like that.
And just kind of, again, to end, there are things that, you know, we're not the font of all knowledge in Greater Manchester. There's lots going on outside of Greater Manchester nationally, but also internationally. And we are forming learning collaboratives, and we've actually formed a strong learning collaborative stateside with colleagues in Staten Island in New York that have a very similar demographic to Greater Manchester in terms of diversity and socioeconomic differences. There's lots we can do with digital technology and WebEx and webinar to share learning. In many ways, actually, they're eager to learn from this programme. They're very interested. And I think there's some partnerships potentially in the future that might help us out in terms of rollout and learning.
Been very, very interesting listening to the comments down. If I may, I'll start at the end and work backwards, because otherwise my notes mean nothing. You know, my writing's atrocious anyway. Margaret, you asked about local links. I think if you could liaise with Lee here and therefore to the members, that we look at policy here, but each of these people are chairs of the local health scrutiny, and therefore it would help them if you could arrange possibly to talk to them locally and put more depth into what's going on in their area. Would that work for you? Yeah. Okay, so that's that one. Thank you, Margaret.
So just conscious there was universities were included in here, but we probably don't have time, but very happy if anybody has questions about that to get in touch with us.
No, it's about getting a feel for the locality, especially with
Okay,
schools.
fine.
My colleagues might thump me for this, but I know more about acute surgery than I do about mental health. I think all of us know about mental health, but how many of us understand it? Am I with a fair comment? Or do you disagree? You know, you made the comment about the difference between mental health and mental illness. I think if you ask people to write those down, the definition, we might struggle with that. Some people might have it, but I honestly believe we've got a surface learning rather than in depth. Your report frightened me to a certain extent. I don't mean at the side of it. I've already told Warren about that. But no, seriously, several points in it. I was frightened because I see you going as young as 5 years of age. I watched it on TV last night. I mentioned it to Michael. You know, we hear about the ambulances and their time, which we'll be dealing with in a moment. But it's the same story. This was predominantly about the police in Devon and Cornwall. And they stated at any one time, nationally, there would be 5.6 patients, clients per minute with mental health needs. 5.6 per minute. Now, just in the one shift, which was what the program was about, there were 5 potential suicides. But they only had 17 officers to deal with Devon and Cornwall. I was always on duty at the time. So it's very different from Michael with his ambulances or you with your thing. With one hand, you say, and I applaud the fact that you are better than virtually everybody else. But on the other hand, it worries me that we're talking about 10%. In paragraph 2.44 and 2.45, by July 20th, July 2020, you'll get to, out of the total of 124, 10%, you'll get an extra 33. That still leaves a lot to be done. Little comments that you made here. I'm old enough to remember the school nurse you talk about now. You don't go with a busted finger. You can go to somebody about stress, what have you. And again, it's something that's been brought out to all of us over the recent months about how teenagers are now suffering incredible amount of problems, incredible amount of stress. Michael, I know it's not your turn yet, but how much do your service have to rely on dealing with young people with mental health problems?
I think one of the things I was dying to comment on really was, two things. One, I was a school governor for 12 years as well. And what prevents young people from achieving well at school is their mental health issues. What we wouldn't, then there may be a lower level on a scale or a spectrum, but it stops them with their exams, it stops them coming into school, as such impact. And one of the growing areas for us in terms of rising demand are mental health presentations, and often they will be adults. But if we make children more resilient, if we deal with children at the right age, then that's going to lead to more resilient adults if the services are in place. So we're seeing the impact of those services not being available when those adults were younger people. So this work is absolutely crucial, I think, and it will certainly make a difference to the services that we provide and how we support the public in Greater Manchester.
So could I just add something that I think is really important, and Warren touched on it right at the beginning. Obviously, this is one of a number of transformation areas in children and young people's mental health, and actually none of them sit alone. They all connect to make it work. So I think one of the really important transformational areas that we have been working on, and it's being implemented as we speak in a phased way, is the crisis care redesign. That crisis response and responding to young people and families in crisis 5 years ago was not good. We, as I say, are implementing in a phased way, so we're nowhere near where we need to be. But actually, crisis means and is different things to different young people and families at different times. But it's then about joining up with all our blue light colleagues have been involved in this, our schools, our primary care GP colleagues, our paediatricians, our families, youth centres, etc. So there's a lot of work going on to join the dots, that system that was not very connected. So there are a number of other areas that actually then join up with this to make the story complete, if that makes sense.
When you were talking, actually, not said earlier on, I drew sort of the schematic of police, NHS, school, and outcome. You're all having to work together, but without exception, you're all very good at what you do, but only over a small section. And that's what frightens me most. I love to be able to applaud that 10% or whatever Michael's figures will be in a moment, but it worries me about the rest. If we can, at the moment within acute medicine, prevention is the word. At the moment we seem to be talking about treatment. How will we get round to doing that prevention?
This whole programme is prevention.
My apologies.
Yeah, the Mental Health Schools programme is not about... that was what... Sorry if I didn't make that clear. That was absolutely... it's why we're not in specialist health. We're not delivering it. Our voluntary community sector partners are delivering that with school teachers, upskilling, not to the point that teachers should be treating, and that's a really important point. We should be doing treatment, but actually what we're finding is some of the reason that young people were not... I think the national figure told us that 1 in 10 young people, now it's 1 in 8 actually, have a mental health problem. That's 3 or 4 in every classroom of 30, but only a quarter of those people were actually getting access to the right treatment at the right time. And some of the problem, there are many issues as to why, but some of the issues around that are not picking things up because of awareness at the right time and then it becomes a crisis. But some of it is actually, because there's nowhere else, specialist CAMS has been inundated with referrals, sometimes up to 60% of which actually don't need specialist CAMS, need something else. Yeah. So hence we're in a vicious cycle, which is what we have tried to change by focusing one of our transformation areas very much and firmly in prevention. And this is all about prevention. And actually, we've also said at national level, and I think Zulfi, you'll remember, one of the questions asked is, so you'll see a reduction in referrals to specialist CAMHS next year? No. I would expect to see an increase, but an increase at the right time, not in crisis, so that we can work in a prepared and planned way where we don't then, we're not firefighting all the time. And eventually, yes, eventually you should start to see a reduction, because actually we have worked in the prevention arena, we've upskilled people, we've got a system that's working together to look at other methods of support. Your point about the 10% is right, because if we can't reach all schools, then you're still going to get that. But that's something I think that we as a whole system need to think now, how do we do that?
Could I just add one thing that we've not mentioned that's really important, and that's about sustainability. So if you think about the group of schools we started working with 18 months ago, well, some of it's about funding, but also some of it's about being really clever and making sure that you're doing things in the right way. So just to give you an example of how we thought about that, all the staff that did the mental health first aid 18 months ago in cohort 1 are coming back to us for what we're calling legacy work. So we're getting everybody back, we're making sure that the work's embedded, we're doing a little bit of a refresher, we're looking at how school policy might have changed, but we have to be mindful that staff change, school leaders change, so I think that constant keeping an eye on things and making sure that we've got that pathway and succession planning is really important.
Moving on through this little list, or the large list, you very passionately, and I would comment again, the whole presentation, Doctor, your passion and your vision comes out very clearly in this, so thank you. But comments about, firstly, the use of other children. I think people are more accepting of their peers than they are from the teacher, the adult. So if you've got children, now with parents slightly different, you use a term that you hated, the parent champion. It doesn't sound right, that either. How do you get them? Because the parents who get involved with the people who they suspect there's generally a problem with their child or a concern with their child. But the trouble is there's fear, lack of understanding. So the first thing I should imagine you've got to do is change that lack of understanding, therefore remove the fear, then you can get the parent to assist you in assisting their child. Would that be a fair appraisal? So how do you expand those parents into helping each other? Because what you're saying, you need that support. How do you manage it?
Well, I think the first thing is that it's not about getting as many parents as you can in and doing a mental health awareness session. It's about embedding the work that we're doing and the language around mental health and wellbeing into everything we do. So that might be, from a high school point of view, at the very first transition meeting you have with parents. It will be something that's spoken about within the pastoral section, so that parents are familiar with that language from day one. I think you alluded to this, but those parents that need to understand most are, I don't really like this term, but they're the harder to reach parents, the parents that perhaps won't come in for parents' evening. So in some cases it's about being really creative and going to them, and it might be having a meeting with parents in a cafe or their house, or, and sometimes, we have parents that don't want to engage with school because their own experiences of education weren't great. So it's about building really good relationships from the word go, and sometimes schools have got to be creative, and that's not just around mental health, it's just around parental engagement in general.
And what I would say is, if I could do this for the whole of my job, I'd do it. Warren, hint, hint. Honestly. But what we don't use enough of, we're not very good at, actually the NHS is really not very good at this, and I will say that being from the NHS. We don't use so we talk about system, and I think again we should learn from our devolution model, and I think this is where we're starting to get a bit better. We don't use our media partners in a positive, proactive way as much as we should. We're generally reactive when we're, oh God, the media is coming to ask us why we're not hitting our A&E targets, or why our children and young people's access times are terrible, and et cetera, et cetera. But actually we should be looking at a proactive strategy around the media helping us to do some of exactly what you're saying. We're getting a bit better at it, but I actually don't think we're developing strategies, co-developing our strategies with the media. Yeah, and the media reaches, sometimes 17 million people out there. I absolutely can't stand Love Island. I've written a position statement from the Royal College of Psychiatrists around how detrimental reality shows like that can be and have been. Anyway, that's a different topic. However, there are certain times of the day, certain shows that draw in massive audiences, that we're not utilising the media in a way that we could get a mental health message out during the break, during the wherever. I know these days it's not all about TV, that actually people are watching things on platforms, on YouTube, that there's lots of, but the media can help us. We're not the expert on that. We've also got radio. We're here in Media City. Everything's moved up to us pretty much. We've got a real gift, I believe, in order to think about some of exactly what you're saying, and I would love for us to be able to do that in a more planned way, in a more proactive rather than reactive way.
Thank you very much for that, Doctor. I remember that it was the 24th or the 27th, your meeting? 30. 30, oh well. Yeah. Can we get some more details out to the team about that, please, Warren? Whereabouts is it being held?
Is it British Muslim Heritage Centre? As well,
It's only men when they get older they start forgetting the details. Thank you very, very much. I'm sure, the members seem to be very engaged with this. We all need to learn more about it. I hold my hand up as I said a few minutes ago. I don't have the depth of knowledge that I should have, and I think most people, to be honest, would like to learn more.
We'd be really happy to do a mental health first aid workshop for any councillors at some point that wanted to do that. I'd be really happy to do that.
Again, if you're there through Lee or through Joanne, but thank you very much for what you've done, and I'm sure that, sorry, Margaret.
Just to add, I think once schools become more aware of this, you're not going to be able to meet the demand, because school governors and teachers really, and students really need this support.
So we need a venture capitalist. We need a venture capitalist to fund so that we can reach all of the schools.
If there's anybody watching this live streaming, just to contact me on Twitter @LisaFathersAFL if you want to invest in this programme, because we would really like to help more children in Greater Manchester.
Thank you very much, Chair. Yeah, the report that we've submitted, I've deliberately included, although I'm here to talk specific about GM, I deliberately included the fact that we're a regionally commissioned service. And I've done that just because there are some benefits to be part of a regional service. So our call taking centre, which is on Princess Parkway, if the demand for those call takers increases and gets excessive, we can virtually transfer calls to our other call centres. Equally, if the demand on our crews is excessive, again, we can bring people across borders to support what happens in GM. So although we've got a 2,000 plus strong staffing group which serves just GM, we can bring in additional resources at times of greater pressure. And we operate that workforce from around 30 ambulance stations across Greater Manchester. And we do get a lot of calls from elected members about where a particular ambulance service and station might be. And one of the things about it is most of the times the crew will not be mobilised from an ambulance station. So once they leave that station in the morning, it's often that once they get to a hospital, they've handed over a patient, that they will be mobilised from that hospital. So the actual point where the station is not normally as big an issue as people would think about it. But we've got those stations, we've got that staff set up now, and we've got that additional support that surrounds it. So that's the basis on which we operate, and we do operate the 999 emergency services, the patient transport service, and the 111 service, which is a regional service, is based in Bolton in Greater Manchester as well. So that's the sort of the fabric that runs the services for Greater Manchester. And so the performance in terms of how we're doing for Greater Manchester, I would say is, as you'll see, and I'll go through the figures in a minute, but has been enhanced because of devolution, because you've got the ability now to do things quicker and faster and go deeper than other counties that we work with have. So that's made a huge difference. So the work we do with Warren and his colleagues and John at the partnership has helped to get us to some of the figures that I'll go through in the report in a minute. So I just think it's useful to have that context in terms of the infrastructure we've got, that's meaning that we're doing better now for Greater Manchester patients than we have done before. So just some figures about our performance then. So last year in 18-19, we were able to take 15,500 fewer patients to Greater Manchester hospitals than we'd done the previous year. And that was consistent across hospitals, whether it was Rochdale, Oldham, Manchester, Salford. We benefited across all those hospitals. Some of the reasons for that, we increased our telephone triage capability. So if somebody will ring 999, often now if it's a low acuity call, we'll get a clinician to call them back. And often we can deal with that issue on the telephone with people. So that made a big difference to how we could then release our crews to deal with more acute, more urgent and emergency calls that we've got through. We've also now trained our staff to manage patients better on scene. So it might be that there's a call that comes through to us, we do dispatch a resource to them, but then because of the clinicians that we now have on our ambulances, they're able to deal with patients on scene. And it might be that they can treat them on scene, it might be that they can make an appointment with the GP the day later, but we can deal with them there without having the need to convey them to somewhere else. One of the great things about Greater Manchester now is that we've got more opportunities to take people to non-ED places. So it might be a walk-in centre, but what we're clearly trying to avoid doing is taking people to the emergency department if they don't need to go there. The more places that we have to take them other than the emergency department, then the better it is for the patient and the better it is for the whole system. So again, because of the work that we've done with Warren and the team, there are now more opportunities for us to do that, because partnership working is the key, and there's some examples in the report that I will just touch on. So in terms of the way that we're going this year, table 3.2 that we've put in the report shows you the demand that we've had on our services this year. So we allowed for around 3.84% increase in our demand this year, and we're already over 8% before we get to winter in terms of demand, increased demand. But what you'll see there in that table, just how we manage those calls. So you'll see that we received over 270,000 calls, but the number of incidents is less than that, the unique patient incidents, and that's because often we get duplicate calls. So an example might be that if there's a road traffic accident, you'll get maybe upwards of 10 people ringing in for the same incident, which we do not want to discourage, because nobody knows if somebody else has rang that call in But what that does is it increases the volume of calls that are coming through to us. But even so, it's a legitimate reason why people ring. So that's some of the differences. Sometimes it could be that, as I said, when people ring us, they're at the most vulnerable, and they're very keen if that ambulance is not coming as fast as they want it to, then they'll call us again and they'll ask us for an expected arrival time, which we can't always give them. Because often what can happen is that although we may even have an ambulance en route to that person, if a more urgent call comes in, then it can be diverted because our calls are assessed on clinical presentation. So there's a number of reasons why the calls received doesn't match the incidents that we actually go to, and that's and what that hides is some frustration from some patients, and also the fact that they're being vigilant and they're calling us because they see somebody else has got a need. And that breakdown there between April and August just shows you how we've dealt with those calls. So as I mentioned, 10% of those calls are now dealt with on the telephone, which means we don't have to send any resource to those patients, and that's only if it's appropriate to do so. You know, we always have to manage the risk involved in doing that, but we'll only deal with patients in that way if it's appropriate to do so. And you can see the numbers for, so over 25% of the people that ring us now, we can deal with on scene without the need to convey them. But when we do need to convey, what you can see there is a split between conveyance to an ED department and a delivery to another part of the system. And they're going right. So what we can see there is our demand is growing, but because we've now got other mechanisms in place and because of the good partnerships we've got, it means we can absorb that growth without basically overloading an already busy ED department. So working with our 10 Greater Manchester hospitals and with the GM partnership, we've now come up with lots of alternatives where people can go other than an ED department where it's safe to do so. That makes a huge difference because we often get asked about our resource levels and do you need more ambulances? And the answer can't be more ambulances. The answer's got to be the types of examples of partnership working that we've put in the report that demonstrates that there's more appropriate ways to deal with patients rather than just the emergency department. What I've shown also for you there is how we do actually determine which patient is a C1 down to a C4. So these are categories that are given to us by NHS England, and this is how we determine the level of presentation and the level of demand that supports us and how we'll deal with that demand. So you can see in 3.5, when these new ambulance standards came in, it takes a while for them to bed in, and you can see the difference now between 1819 and 1920, the first quarter of Greater Manchester's demand and how we dealt with it. So you can see in the first year we're only hitting one of those standards. So it's taken time for us to adjust to that, so we had to change our infrastructure, we had to get more double crewed ambulances and change the way that we work. But as you can see, as we've started to adapt that model now, you can see this year, in April, when we compare with last year, across every standard we're improving. We're hitting 3 of those standards, and we're pleased, but we're not going to be satisfied until we are those standards and the patients get the best deal possible they can get from the ambulance service. I think it's probably just worth touching on some of the reasons that we have to manage our demand in the way that we have. As I mentioned, activity levels, we can't control activity. We can't honour what we'd want people ringing us because when you compare the Northwest with, let's say, the Southwest, a different type of patient. I mean, we sort of joke with the ambulance service around Bournemouth and Dorset that they have the worried well. And we have people that have got real clinical problems, and the presentation of clinical problems is very different in the Northwest than it is in the Southwest. So activity levels have continued to rise, but it's, as I say, it's how we manage those activity levels that's really important. One of the things that we've mentioned in the report, which again we're getting much better at in Greater Manchester now, is our hospital handover times. So because of the demands placed on hospitals across the Northwest, we can turn up hospitals with patients, and we have a turnaround time of 30 minutes, 15 minutes to hand over the patient, and 15 minutes then to get our crews ready, our ambulance ready, to go against the next call. And in winter and other places, you can imagine that time, because the pressure can increase. But we've had some great partnership working now. That means that we're much closer now to that 30-minute period. And that's really, really important, because what we're waiting to get away from is we'll know that there are 80 to 100 patients that have been triaged by our call takers that we can't get to if our crews are tied up in different places. So the fact we've made massive strides in turning those round, it makes a big difference to patients in Greater Manchester. Because what can happen if we can't get there quick is that patient can deteriorate over hours, you know, and so it's really important that we're able to do that and we're able to get to those patients. Just a couple of more things I wanted to mention really. Again, the alternative care pathways. It is really important. I think the education piece and prevention piece that was mentioned by Lisa and by Sandeep is just as relevant for the ambulance service. What people seem to know at the moment is if I ring 999 or if I turn up to A&E, I will get a response. So one of the things that we're doing is working with, and one of our plans this year is to work with GP practices. A big part of our demand comes from GPs and the patients that go to GPs initially. We want to come up with an offer in line with the GP primary care strategy in Greater Manchester, where we might look to rotate paramedics and other clinicians through GP practices and look at how we can prevent some of that demand, how we can deal with some of those patients at source. And it might be that when they're in that area, we still respond to category 1 calls that are close by. So it comes back down to partnerships, and it comes back down to how we can develop those partnerships. One of the things that we're pushing to get on the curriculum, and hopefully we'll get that over the next 12 months, is things like even first aid on the school curriculum and how to do, how to resuscitate somebody from a young age. Because if we can get children at a young age, makes a huge difference. We think wherever there's a fire extinguisher in a building, there should be a defibrillator. Because you would argue there's more chance that defibrillator being used now than the fire extinguisher being used, and that's because of the success that we've had in fire prevention. So a big part of our agenda will be about prevention, will be about working in partnerships, developing those partnerships. We've had a partnership running in Greater Manchester. It ran and it completed earlier this year, and that was about dealing with people who've got an urgent need but not an emergency need. And what we've done through the Great GM Partnership is we're working now with 3 out-of-hours providers, and so we transfer certain calls straight to those GPs, straight to those nurses, and that means they can be seen quicker. Because when we've got this priority order that we go and see patients, depending on the seriousness of the case, passing those patients through means they will get seen sooner and by a more appropriate clinician. So we're looking to stand that and extend that pilot back up again over the next few weeks, again to make sure that Greater Manchester patients get a better deal and they're seen by an appropriate person. What we don't want is the stories that we get where people are waiting 4 and 5 hours for an ambulance because the demand increases. If we can safely work in partnership and pass those patients on to more appropriate clinicians, then that's what we want to do. We shouldn't have that work just because we can do it. We should work with people that are best placed to provide the best services for patients. You mentioned 111, it's not in the report, but that 111 contract is due for renewal next year. And so we're currently engaged in discussions with commissions about how that will work, because as you quite rightly pointed out, Chair, and some of it's a lack of understanding of what 111 can do for people. It does get a huge amount of bad publicity, or it certainly did last year. That's been developed, so people can access that service online, and there's governance wrapped around that to make sure that's done safely. But we're looking at how we manage 111 demand, and again, it might be that our service takes the call, but again, that we then pass that on to more appropriate services. And as I mentioned earlier, we deal with all the regions across the Northwest, and GM are in a good position because of the way that the managing health and social care, that they can set up and stand up things quicker than other counties are able to at the moment. So we are seeing benefits. So the reason I think we're improving in our position in the service we provide to GM patients is because we've got this infrastructure that's building and building all the time now, and that's got to be better for patients. So I go and speak to directors of adult social care, I speak to acute chief executives, again, just to look at how we can do more to make sure patients will only ring 999 if it's an emergency, where there are other things that they need to pass up, because we need those resources to be available for time-critical patients in the first instance. And if we've got crews dealing with things that other people could deal with, then we want to keep working on those partnerships. As I said, we have a separate set of commissioning intentions in Greater Manchester that we don't have in other counties, and that's because the way that you combine and work together puts you in a stronger position to best serve the people that you represent in your local neighbourhood. So we do things down to local neighbourhood level. So in Tameside, there's a Skype service. So there's a service where in care homes or residential homes, they'll Skype into hospital and they'll deal with those symptoms, they'll deal with those issues. If they can't do that, then we've paid for a car that the nurse can jump in and drive to that home and deal with it on scene. And that in itself has stopped so many ambulance call-outs because that patient's been dealt with appropriately by the right people. And, you know, I put an example in Wigan where we've sat down with local authority teams and had the same outcomes, that less ambulances are called and there's a better deal for patients because they're being seen by the right person. And it's not that we're not the right people, but there are other people that can make a bigger difference at the right time for those patients. So there is a big education piece that goes on from us about only ring and we'll set up our winter comms, we'll come to winter planning days in GEM to make sure that we get the messages across to people. Because I've sat and I do sit in acute waiting rooms in hospitals, and I've seen examples now of people ordering food in. I can't remember the name of all the delivery firms that there are now. Is it Just Deliver or Just Food? And people have ordered pizzas to be arrived because what they've worked out is that I can have my appointment, I can have my x-rays and we're done in one day. But it's not appropriate almost a lot of the time for them to be in there. Most of the time they won't have any treatment there. So a big education piece is, and we've got better but need to get even better at making sure we're stronger at building those partnerships. So I'm pleased to say we're doing better for GM patients than we have done in previous years. As I said, you know, although we're pleased with that progress, we're not satisfied, but we can't get better in isolation. We can only get better by working with the people around this table. I'm happy to take any questions.
Thank you, Chair. Can I look first of all at table 3.5, which is improvements in service and performance standards. So great that the C1, the life-threatening time-critical injuries, you know, clearly significant improvement over the last 12 months. Absolutely great. I probably do need to tell you that the first job I had in the NHS in 1974 was developing a computer model for the emergency ambulance problem. And at that time we were talking about ORCON standards, long time ago, but that was all in terms of percentages. And what puzzles me in looking at this is that there's the distinction between the 90th percentile for C1, which is now down to just under 11 minutes, great, and the C1 mean. I'm actually really surprised that the calculations in terms of mean, because clearly the response times have got an enormous tail. And depending on the length of that tail, that can change quite dramatically the calculation of the mean. I'm really surprised that you're not using the 50 percentile. Yeah,
it's a very good point. I mean, these standards are set for us nationally. The idea of having the 90th percentile is so when you look at it, so the idea is that 9 times out of 10 that we get there within 15 minutes. Because you're right, that the mean, the average can hide. So we have a team that work on the tails, because one long wear can damage that. But the most important thing is that we don't want patients having that long wear. And just to go on to one of the things that you might have gone on to say is that you see a worsening of that thing with C3 and C4 patients and the longer time they have to wait. And that's why it's important that there are other things in place. So we don't want C3 and C4 patients, because although we class that as urgent, not emergency, if it's you or you're a member of your family, it feels like an emergency. Because there's still, a fall can be classed, it's a fall, but when you fall, you can damage your head. There's lots of things that can be already poorly, and you fall, so it can hide things. So the way that we do our work is we make sure that we have a team of clinicians looking at tails, So we have some headlights, if you like, some traffic lights within our system that make sure if we reach a certain point, we start to ring that call back. And we could re-triage that call, and we need to see if that patient has deteriorated or not. So these measures are important to us, but it's what you do underneath those measures that's really important.
Thank you. And certainly your comments earlier about linking in with GP practices and other ways in which you can respond to that particular need, I think is exactly the way to go. Thank you very much. Really interesting.
Just to kind of emphasise a couple of points that Michael's touched on, because actually, if we think about a sort of period of history over the last 10 years or so, what Michael's described is actually quite a significant shift, I think, in terms of the way that the system works together in the context of integrated urgent and emergency care. And Michael's kind of final point really is really critical. You can't get better in isolation, and there would definitely have been times historically where we would have had a conversation about ambulance performance, and it would have been about the ambulance service as an individual entity. Whereas actually, some of the things, if I could just kind of pull out some of the points that Michael will have alluded to, you get a real sense then of, so what does the local system do? What's the local system's responsibilities in order to ensure that we've got a shared objective about the right type of care delivered by the right kind of professional at the right time. So it's one of your mantras, Chairman, I think. And a couple of things that feel really essential that we know are happening. And I think what we'd acknowledge is that we're in a process of evolution around these aspects actually coming to life in all parts of Greater Manchester, and Michael's picked out a couple of the more developed parts, I think. But where we've got that set of attainable objectives around same-day primary care, around primary care not being an isolated corner shop part of the system, but actually coming together in the context of the neighbourhood model, reinforcing its own resilience, strengthening its service offer, making sure that it's got an eye on those patients in that community that are most likely to be high users of urgent care, and it's thinking alternatively about what does it need to have in place in order to head off that crisis. And then there's a really, really critical part of the emerging model that I think will be the game changer in terms of ambulance performance. And that's the development above each of those neighbourhoods of what we might class as a kind of an intermediate tier. So some of the examples that Michael was describing around, community response teams operating in each of the 10 districts, that enhanced care around care homes, some of those kind of extensive care models for the people that are most likely to be high users of emergency care. I think we've got a couple of quite advanced and stable models that are pretty comprehensive, and Wigan, Tameside, Rochdale, I would say, are some of those that feel firmest in that. Salford actually might not be a million miles away from that as well, but they're developing in all parts of Greater Manchester. It's just worth us having in our minds in terms of what does our local system look like in the context of this set of performance figures. There's kind of bottom up and top down, if I can put it like that, in terms of the way that the ambulance service fits with the local system. So we've got to be quite proactive actually about thinking of the integration opportunity in each of the 10 districts as part of the backstory to Michael's presentation.
Chair, if I could just add to what Warren said, I mean, there are many examples across all the neighbourhoods, as he said. I mean, I can think of Glossop, which is sort of isolated. It's in Derbyshire, but it's part of Tameside, and we have a community specialist paramedic there that does a fantastic job, and is absolutely part of that community. And the other thing is also sharing resources as well. So what we don't want to do really start employing mental health workers. They're already a scarce resource. If we've got a GM resource of mental health workers, because the police have recruited mental health workers, we could recruit mental health workers, and actually local authorities struggle to recruit mental health workers. So there's something about sharing our workforce as well, and you can only do that in an integrated model. And I'm hoping that, if we can present again, we'll be sat alongside other providers, and then it will be clearly demonstrable to you that we're part of the system. We can't stand outside of it. We're an integral part of it. And that's where we've just approved our strategy, our urgent care strategy, and we're having a strategy launch there. And that's about how we'll look very different to what we previously looked in the last 5 years.
I just want to comment on the partnership working that Warren and Michael have spoken about. Many of you know my daughter's 47 and severely brain damaged and lives at home. She was query sepsis a fortnight ago, and the ambulance came. Wasn't sepsis, but she did need urgent care. They came. It's pneumonia. So it meant that she didn't have to have a spell in hospital, but it's adding to the quality of her life, not having to go through, a traumatic experience of going into hospital. So I think this partnership work is absolutely essential. It's taking pressure off GPs, taking pressure off the ambulance services, and adding to a better quality of life for patients. But in terms of the 111 service, which I've had, a few occasions to use in the last year, absolutely brilliant. Not found any fault with it whatsoever. So I don't know what the other problems are. If it's appropriate for you to phone them, their response is first class.
Thank you. A couple of weeks ago, we had a presentation from North West Ambulance at Oldham's Health Scrutiny, and I must say they were very impressed by what we were told. You're quite right, education and behaviour change is something that needs to happen because the demands are so great. And last week I was at the pub watch for my local area, and we were talking about defibs and encouraging the licensees to buy them. There are a lot of myths about them, and we tried to explain, because we have invested previously in using our budgets to purchase some for strategic areas. But what I'm really interested in, getting to the question, is recruitment and retention. You've got 2,050 staff. How do you go on about, it's a very stressful job, how do you go on about keeping them, and do you have a plan to get more?
At one time there was, and I'm now talking the last 18 months, paramedics were on the occupational shortage list. So we went from having a 14% vacancy gap, and having that vacancy gap is a clinical risk, because what you sometimes had is 2 technicians who weren't as qualified on an ambulance. We're now at full establishment in Greater Manchester for paramedics, which is pleasing. There's an opportunity and a challenge in the work that we'll do on the GP primary care, because GPs are sort of being encouraged to think wider about their workforce, which includes hiring paramedics. And across the Northwest in total, and one of the probably the time that we've got in Greater Manchester, there are over 1,200 GP practices. So if they all did that in that singular way, not working together, it would be an issue. So clearly it's up to us to work in partnership to make sure we have a different offer for that. You're right, it's a job with its challenges, there's no doubt about that. And just to give you an example, we have around 1,300 assaults every year on our staff. Physical assaults, from having blood spat in their face to being hit physically with weapons. And so what we don't want them is to think it's part of the job, because that's what they say to us. It will never be acceptable for that to be part of the job. So we do a lot of work in terms of protecting our staff and educating our staff. We do a lot of work on resilience with them. We offer trauma risk assessments. There's lots of health and wellbeing work that we do with them. We still do find that there's turnover, because I don't like to use the word burnout really, but actually there's a level that you reach where I think job after job. Now, interestingly, in Manchester and say Liverpool, where it is literally job after job after job because of the urban build-up that you've got. In other areas, it's not that. You can travel an hour to see a patient and back. So it's different. So we offer the ability to move around to different places if they want to work in different places. So we do a lot of work on making sure we keep them well. I mean, our sickness figures are improving year in year, and that's partly because I would hope that we're looking after staff in the way that we are. I think I mentioned the ambulance programme earlier because it was mainly focused on Greater Manchester, and the response we got from the Greater Manchester public was fantastic. And our staff, knowing they have that support, makes a huge difference, because when there are delays of responding to patients, there's nobody more frustrated than our staff, because their job is to get to people and to support them and help them. And so we'll keep working with them on that. The point about defibs, it's an interesting one. I'm of an age, I'm not going to put anybody else in my bracket of what age I am, but people are still frightened of doing CPR, are still frightened of what a defib will do. And what we tell you when we do training is actually that person's dying. So if you break a few ribs, you know, it's okay. We'd rather you break a few ribs than let them die. So the response, you know, so it's really important that we do, and we do a lot of work in Greater Manchester on, we have a lot of volunteers, we do a lot of work with them in terms of training, we go around schools and we do education work. But there's more that we need to do. Possibly 3 to 4 years ago, Andy Burnham, when he was an MP, invited us to House of Commons so we could, and you have to be invited, so we could talk to MPs about the need for more education, the need for, and for adults as well. Because there are lots of defibs and people, we need to know, if people buy defibs, we need to know where they are so we can register them. So if we get a call in, then we can point people to that defib. And so there's a lot of work that we do with communities, but it's not enough yet, and there's more to do, Councillor Moores, in that regard.
Michael, I don't want to leave this to the summing up. This committee over the last year have gone back to their councils and back to all of their colleagues. There were 600 councillors in Greater Manchester. They were all spoken to by people like yourselves, ourselves, to actually ask them to help identify. And one of your operations staff used to come in and talk to us about this. I can't remember his name. But we fed back that information because we were concerned that there were about 4 apps saying where your nearest defib is. You've got your staff on Princess Parkway.
Yeah.
With 90% knowledge, but there was no 100%, and we've helped improve that. These guys here and their colleagues have helped bring that together. I'll say more about what we've done, but I just wanted you to be aware that this committee have been quite a strong force in improving that.
The good thing about that is most of the questions I was going to ask have been answered. What I was largely reflecting on, which is maybe more for the wider everybody around the table rather than necessarily just for you, Michael, is just how to best scrutinise some of this. Because I think what the benefit of coming here is you get the overview for Greater Manchester, and then in our own health committees, you know, we scrutiny committees, we get to see it in our, so for me, in Manchester. I'm struggling in not having the two side by side. So I was trying to get the information. I couldn't unfortunately do that on my laptop. So it's just getting that real sense of the benchmarking. So it's great when you hear that, you know, what's going on in Wigan. Immediately, I kind of want to go on what's going on in Manchester and how can we gain from that better, and what can we do again back in our health scrutiny committees to make sure that we're sharing that. So it's some of that information that I just think maybe even if it's just a summary of for each of those districts, that we can really kind of locate ourselves in that, so we can be clear that if it's still coming up on our agenda, that we're getting the information for our local district, and if you just had it like you have, then you're in the advantage of just having that information fresh. So it's a question about how hopefully we can then help you in that process and ask the best questions, really.
Warren or Michael, can one of you arrange to have that data sent to Eve, please?
Yeah, because I was wondering whether a good thing might be some of the outputs that we did on the back of that winter summit earlier this year, because there's a picture by locality that gives you some of the performance data, which I think we might be able to update, but also gives you a bit of a snapshot of what does that local system look like, so we can understand where the kind of key relationships are. So if we dig those out and circulate, and then the other thing I'm thinking is we've got this kind of Tableau system. It's live performance reporting, and our business intelligence person loves new people joining that system. So we could also set up a kind of access for each of the members on that. And there's all kinds of things that you can explore in there about the performance of the whole system. So it's if people are digging into performance, there's loads of fabulous stuff that's presented on that.
Yeah, just say thank you. That would be really welcome. I think that would be really useful in terms of understanding it. And I did have one other question, which is just around, it's great to hear, you know, use technology for Skyping, for example, in care homes to alleviate the problem. Just again, I don't know how widespread is that? Is that something that, again, it's great to hear best practice, but you then go, I don't know at a local level or how many care homes we're talking about have actually taken that step.
Yeah. Okay, I mean, I think it goes back to your other question as well, really. I think you've seen examples of what's happening in other neighbourhoods and other areas. It just allows you to ask the question, and Manchester may be doing some fantastic things because you're in a different position, different patient groups, different priorities, but it still allows you to ask the question of why aren't we doing that? If we're not doing that, that's okay, because I understand that you're doing this instead, but when are we going to do that, and why is it? So I think that neighbourhood description that Warren talked about will be really helpful for you, because we see people do things at different times, because it suits their patient cohorts, it suits their service users at different times. But yeah, I agree, without that coverage, you can't compare and contrast what's happening and ask the questions, which is clearly what a scrutiny committee will want to do.
It's well, Warren's here as well. We've got our improving specialist care programme, and one of my big bugbears is transport. Is there anything the ambulance service can help with that, to get patients, you know, to all the different areas and the visitors and the relatives? Do you have any transport assistance?
So we run the patient transport service for Greater Manchester. We've got a contract, I think, till 2021 to carry on doing that. Yeah, it was Arriva ran that for 3 years, and then it came back to North West Ambulance Service, and I think it's due back up. We're talking to the Commission about how that service runs, because I'm saying this with the greatest of respect. I think it's one that we get freedom of information requests about from taxi firms and transport firms, because I think they think that's what it is. And I think we're taking people for appointments for renal treatment, for cancer treatment. So there is a clinical aspect to that. So we run that service, and so if people meet the threshold and then they qualify, then we will pick them up either through a contracted taxi firm or through one of our own ambulances. Again, depends on the clinical need of the person. And we transport them to hospital for a further appointment, and then we'll take them back home as well. So I don't know if that answers your question.
It does in a way, but I think more, as he says, more detail about how it works, because for Salford, which has low car ownership, it is becoming a bigger problem.
I think this might be a point, and please don't think I'm having to pop at anybody here. The way this committee works, as you know, Mo, is looking at GM policy, but we've got 10 authorities, most of which you are chairs of health scrutiny. So where it's local specific, I think, you know, Michael, it's best if we learn now to start dealing with the locality about their concerns while we do the policy. It's worked very well for us. If your question are all answered at the moment. Yeah, right. 3 years ago, when we brought Derek and Co into a closed meeting, it was about ambulances stacking up at hospitals, patients waiting an hour or more, people lying on the road dying from RTCs. You've changed that. You've changed it radically. And I'm not being rude when I say I'm not concerned about the 5 minutes or 2 minutes, which is performance data. That's management data. What we, dealing with the public, need to know is, will you get there sooner? And it's not necessarily an ambulance, as you verified. It's about, will that patient or that patient relatives have some comfort that there's either a doctor talking to them, to be phoning back, keeping them informed, or there will be a paramedic there, and maybe an ambulance to take them on to a trauma unit or whatever. That, I think, is the biggest improvement. And that's what I think, as a GM committee, we need to know about. I'm not being rude when I say about you. There's a lot of work there about your 90.927 and 10.09. Great. Repeat, that's management data rather than practical stuff. Margaret, you talked about your daughter, who's a very vulnerable person from what I've heard from you in the past. By the paramedics making that decision not to take to hospital, possibly saved her a lot of trauma, because she's got so much chance of picking up further infection in the hospital, especially around an A&E where you've got a lot of people who are very vulnerable as well. And I think that was a perfect example of the way the system's changing, actually helping people like your daughter, and I think we should be very grateful for that. Working together, partnerships. Very, very important. When you were talking, I got this out of my pocket. You, from Wigan, would possibly know what that is. The fire service sponsored dementia-friendly, dementia buddy system, put several £1,000s, well, tens of £1,000s into doing a pilot for the across Wigan Borough. I think we all know somebody who's got dementia, male, female. If you imagine, they can either have that on their keyring, or they have a little bracelet, or they can have a brooch, badge, or even a handbag tag. If I found somebody wandering around looking a little bit unsure of themselves, I could take my phone out of my pocket, tap that, the NFC, the thing you get to pay at the till, pick up the information there. In my case, it's a demo. It just says, John O'Brien, 07836, blah, blah. It's to prove that just by you, not knowing me from Adam, can touch that, and there'll be a contact number for that person. That was a big strain on both police and ambulance. How many dementia people did you get called to?
I couldn't take the number off the top of my head.
No, I wouldn't expect you to, Miles.
But we do, I mean, and that's one of the reasons, as part of the annual manager training now, for all our staff, we do dementia-friendly training, dementia-friendly awareness training, because often that's not the presentation, that's not what we get the telephone call about. That's not what we get the call about, but when we get there, what's presented to us is often something different, and that person may be suffering from dementia, but the call was about something else that had happened to them. But again, recognising those signs and symptoms, our staff can pick that up because of the training that they've had now. We're also just looking at dementia-friendly ambulances as well, at the point where, because again, other people have done that. We have ambulances for different reasons, and it's hard, again, to cover the whole patch and find that one ambulance that might do it, but we're always looking at the possibilities of how we can make sure that when people do contact us, we provide the very best service we can. So that's one of the things that we're looking at. So 3,000 plus staff have been trained in dementia awareness, and they've signed up, and they're all dementia friends now. But we're doing more work in that area, because it's one of the things, and Councillor Morris, you mentioned sepsis. Again, it's a big threat now. And again, we're making sure that we have specialists in sepsis, that we can recognise those signs early. So all these things that are coming up, these are things that we have to respond to, because these are the demands that are coming from the public now.
One of the things I saw at Parkway was the joined up writing. Rather than just having people actually fall to talk to Margaret or talking to Keith, it was about Margaret sepsis, right, we want you to talk to Michael. It was about people being able to transfer their skill across. And we've been trying to arrange that trip. Lindsay has done so much work in trying to type with Derek about a visit to Parkway. There were offers and promises, as you know, of us using committee room. I believe you now in your position can tie all that together. Yeah,
I can make sure that you can have a meeting there. We'd be delighted to host you, and we can take you around Parkway Centre. You can see how the call taking happens, and you'll see a range of calls, from very serious calls that have got life-threatening consequences. So some calls are people that probably shouldn't be ringing the ambulance service, but they do. So I can tell you one I heard a couple of weeks ago, and it's not to trivialise it, but it's just to show what people's mindset can be, that somebody had burnt their hands on the straighteners while they were getting ready for work, and they want somebody to go around and see them because they've got blisters on their fingers. So there's a whole range of calls that you see that, and we get, and as I said, we don't judge those calls. To that person, they're serious, but we're not going to be sending that person an emergency ambulance. But to see that in action, and what you'll find is a very calm environment. It's not what you imagine a call centre to be, and then you can see where and how we dispatch vehicles as well, the way that we do that.
The other one, since I'm asking for favours, you and I both know about the new ambulance station at Wigan. It's our sort of flagship at the moment, isn't it? About how ambulances are replenished, then go back out and they run. They come in, load up, and park up, and they're ready to move. I would like, outside of the meeting schedule, to arrange for, or ask you to arrange a meeting where the guys can go up to Wigan. We'll find a way of transporting people if maybe get up to Wigan and do a visit at the ambulance station and see a modern ambulance station in process.
Yeah, we can do that. We have. It feels like a visitor attraction sometimes, that centre now. But you know what? That's great, because we never want to miss an opportunity to share what we do. Because if you know what...
I've got the scars from...
Yeah. But if you've got a greater insight into what we do, as you said, you know, as Councillor said, when you're at your scrutiny committees, you're that more informed about what we do, and also you're in a better position to challenge us as well, because we need equal measures of support and challenge. We get pushed on to greater performance in GM because of the way that you set up now, and that's good for patients, and we're up for that. But happy to host that visits, and yeah, that's make ready. It's called. So literally, they'll drop the ambulance off, and we have teams of people that get the drugs back in there to the right levels, get the equipment back in there. So yeah, happy to arrange that.
How many of you would be interested in going and seeing that? All of you, I thought so. Right, I'm conscious of time, Michael. We've taken up a lot of your time, and I'm running out of time with the committee timetable today. All I see is improvement, and I don't mind my colleagues, but I would like say on record that the improvement is well received. The diversity of the resources that you're bringing into play, again, well received. The change in attitude about how we deal with those 999 calls is possibly the key to doing that. The other things that you and I talked about removing resources, and Warren touched on it. I do have a bit of a bee in my bonnet about the right place at the right time for the right outcome within the resources available. It's not about getting more resources, it's about using the ones we've got. And everything you've told us today shows that this new attitude is doing that. So I'm sure we'd all agree that to recommend, well done. Okay. Right, folks, do you want to do a work plan or not? Yeah, go on.
Thanks, Chair. Yeah, the Scrutiny Work Programme for the Joint Health Scrutiny Committee is on page 73. It's up to members to... It's not written in stone, it's a live document, and we've planned out work up until the March meeting, so if members are in agreement with that, or if there's anything you feel that you would like to add, we can do that.
As long as it's a GM concept, not
Yes.
a borough concept.
Just to clarify, Chair, as well, when we're talking about going to Parkway, are you wanting to hold a health scrutiny meeting at Parkway?
Yes.
So one of the scheduled meetings will be held there?
That's right.
Okay.
We were promised this, what, a year ago, Margaret? Sorry, I think it was, thank you. It was with the change of management, and I find it quite refreshing, and Warren's smiling there. But, you watch some of the concerns we had, Peter, John, myself, concerns we had with this service. This is a refreshing change. I know it's all new and it's bedding in, but if it carries on the way it seems. Now, there were problems. We're told there was nowhere to park. That's rubbish. There's plenty of parking if it's pre-arranged. The other problem is transport, people getting there. Now, you drive yourself, don't you, Keith? All right, I'll ask the question anyway.
I can, but I prefer not to.
Yeah, all right. Could you get to Parkway with us? Yes. Margaret? Yeah. And, yeah. Basically, there are people who have expressed concern, and Lindsay's tried to accommodate that. We are trying to work as a team, and we will find solutions if you share it with us. I think we've learned quite a bit today. I certainly have. And I really thank you for your participation in that. And with 4 minutes to go, is there anything else that you wish to deal with? In that case, thank you all. Thank you to the staff. Thank you, Warren. Safe journey home.